Good afternoon, everyone. Welcome to our webinar. This is hosted by the Baker Institute, and I will give plenty more information about the co-sponsorship. I want to make sure everybody is in the Zoom room, and it looks as though we have everyone. I've started the chat over here. So thank you so much for joining us. My name is McLean Sampson. I am a fellow in reproductive and maternal health at the Baker Institute. I'm in the Center for Health and Biosciences. I'm also in a dual appointment over at the University of Houston, Graduate College of Social Work, and in that role, I am the principal investigator for the Healthy Start program. Through my collaboration with Healthy Start, we are in an alliance with the other Healthy Starts in the site, and we decided we'd love to host a webinar to help raise awareness among people who run programs like Healthy Start, people who receive services from programs like Healthy Start, any academics, scholars, all of those people as well, about these recent changes to Medicaid. So what we'll do today is I will give you an overview of the center and the program. I will give you a little bit of background about what is going on with the legislation, and we will then turn it over to a panel where I will ask some questions. And I think I'm going to do something a little bit different. Usually we give all that information first and then we introduce the panelists, but I'd really like to introduce the panelists now, because just as the people who run the programs, all of the people who are on our panel are instrumental in making change happen. So I like to really recognize them first. So we are joined today by Representative Toni Rose, and she was elected in 2012 to represent Texas House District 110, which encompasses the communities of Oak Cliff, Pleasant Grove, and Balch Springs in Dallas County. Her legislative focus includes mental health reform, access to affordable health care, and criminal justice reform. Rep. Rose was a primary sponsor for HB12 that will be expanding Medicaid coverage for 12 months postpartum. Thank you so much for joining us today, Representative.
Thanks for having me.
Yes. Let's see, our person from the state was going to be Valerie Mayes, and I'm going to use some information that she gave me. Unfortunately, she was not able to be here, but she is with the Medicaid Health and Human Services, so she knows all the ins and outs about Medicaid, and I really appreciate her contributing some information. We're also joined today by Dr. Carla Ortique. She is a Houston-based obstetrician-gynecologist at the Women's Specialist of Houston Clinic. There, they accept private and Medicaid insurance. She's also the chair of the Texas Maternal Mortality and Morbidity Review Committee, which investigates the causes of maternal death and illness on behalf of the state. Dr. Ortique was recently elected to be the president of the Texas Medical Association Foundation. Welcome, Dr. Ortique.
Thank you for having me today, and thank you for convening this panel.
Absolutely. It's always a pleasure to see you. We're also joined by a new friend of ours that we have been very excited to meet through Healthy Start. Her name is Yenny James. She is a community health worker, and she is also a doula. Yenny is a doula and maternal child health advocate who has dedicated over 10 years of her career to supporting families in communities that have been disproportionately affected by the country's maternal health crisis. Her experience in the perinatal health space and obstacles that she faced as a mother, a Navy veteran, and a Dominican immigrant led her to found Paradigm Doulas. Welcome, Ms. James.
Thank you so much for having me in this space.
Yes, absolutely. All right. So I came up with a very basic PowerPoint just to give us a little bit of structure here. Okay. Let's see if I can go back up. Okay. So today's webinar is how new Texas laws may improve care for pregnant women receiving Medicaid. It's co-sponsored by the Baker Institute Public Policy, specifically the Center for Health and Biosciences and the Texas Healthy Start Alliance. I'll be moderating today, and I've already introduced myself. So for those who don't know about the Baker Institute, it's a nonprofit, nonpartisan think tank in Houston. Our institute produces independent research on domestic and foreign policy issues with a focus on providing decision makers in the public and private sectors with relevant and timely policy assessments and recommendations. By bringing statesmen, scholars, and students together, the institute broadens the content and reach of its policy assessments and recommendations and provides an open forum for debate and discussion. It educates students on public policy and related subjects by offering courses at Rice and sponsoring student, intern, and mentoring programs at home and abroad. And I really appreciate the platform that Baker provides for things like these kinds of discussions that often get highly politicized, when really what we need is a discussion just on the policies and to talk about the potential benefits and the potential access issues. I'd like to tell you a little bit about the Healthy Start Alliance. So with funding from the Health Resources Services Administration, which is HRSA, over 100 Healthy Start sites nationwide seek to reduce the risk of infant and maternal mortality. The Alliance actually includes all of the sites that are in Texas. Since Texas is so large, we're fortunate to have we have 5 sites. We have one here, the University of Houston Healthy Start. There's one in Fort Worth at University of North Texas, and Dallas at Parkland Hospital, and in Tyler and San Antonio. Each Healthy Start site is tasked with serving up to 300 pregnant women, 350 postpartum or babies, and 100 fathers at each site. So you can see the potential public impact of having a Healthy Start in your city. Collectively, our alliance, so across the state, we've served nearly 9,000 people just in this funding cycle. So that's just since 2019. And we all know how 2020 to about mid-2021 went during pandemic and services. So it's quite impressive, the reach we've been able to have. I also wanted to just give a quick plug for Healthy Start. We do provide services in the community. I think that's something pretty unique about Healthy Start. We have to find which zip codes have over 1.5 times the national average of infant mortality and then serve those zip codes. Each Healthy Start has to be actually located in the communities where they do serve. And we do wraparound services by providing home visits. And we have doulas, we have mental health providers, we have a nurse. Each Healthy Start might have a different clinical provider, but we all do wraparound services and strive to connect people to meet their social determinants of health as well. The context for the discussion today is we are, as Yenny says in her profile, in a maternal health crisis in this country. In this state, the Texas Maternal Mortality and Morbidity Review Committee report that came out earlier this year reported that major racial disparities in maternal mortality persist. These are disparities that have persisted for decades, and it is imperative that we address the disparities. Over half the births in Texas are financed by Medicaid. So any changes to Medicaid, especially things that give more benefits and more inclusivity, have potential to make a major impact. Recent policy changes extend benefits to 12 months postpartum and seek to increase screening and referral for non-medical drivers of health, also known as social determinants of health. And community health workers and doulas will be considered in Medicaid benefits. So we're going to talk specifically about that legislation. And I also wanted to give a little bit of context as far as the numbers around the crisis. So in that report by the committee, when they revealed that disparities were still persisting, Black women, more than other racial groups, we're dying at about 117 deaths per 10,000 hospital deliveries, which is over double the rate for their peers who are white. So that's what I mean by racial disparities. We see the same thing with infant mortality. The rates among infants who are Black, they're dying at about twice the rate. And infant mortality is when an infant dies within its first year of birth. So the main purpose of this webinar is we really wanted to increase awareness among providers. A lot of providers on this call likely serve populations who are on Medicaid, and we are hoping that there's also representation today from women who are on Medicaid themselves and will be enlightened about possible changes coming up. Well, there are changes for sure. The possible part is the date. Okay, so let me see what I've got here. We talked about the panelists. Okay, I'm going to stop sharing here so I can go back to normal view. Okay, so in this last legislature, they recommended that we go ahead and advance towards making an amendment on the Medicaid postpartum coverage from 60 days, meaning 2 months postpartum is what Medicaid coverage has been, all the way to 12 months. I'm going to give a quick overview about what these bills are, and then I'm going to open up the panel to ask some questions about the bills. So the speaker who I mentioned from the Texas Health and Human Services Commission, who's not able to be here today, Valerie, sent along this language from the commission. They did publish recently a public notice of intent to go ahead and make this change in Medicaid and CHIP to extend it to 12 months. HB12 is what it was, and they are characterizing it as the 12-month postpartum period begins on the last day of the beneficiary's pregnancy and extends through the end of the month in which the 12-month period ends. Individuals who were enrolled in Medicaid or CHIP while pregnant and are still less than 12 months postpartum, but whose coverage was terminated prior to the effective date of these amendments, will be provided continuous eligibility for the remainder of their 12-month postpartum period. There was also a previous amendment to CHIP, allowing for 12-month continuous coverage for the children. The effective date for this proposed amendment, though, is March 1st, 2024. So that's something we'll be keeping in mind as we discuss this on the panel today, because many of us are aware of, since Medicaid was not expanded, it was extended the length of time, but it was not expanded. So there are thousands of people who are without Medicaid right now who are trying to re-enroll. So that's HB 12 for 12 months. And then there's HB 1575, which is about the non-medical determinants of health. This is a new law requiring Texas Medicaid to develop a standardized, strengthened screening tool to help determine non-medical health needs. For example, these are things like housing, income, education, workforce, insurance. Those are really things, I think of them as social determinants of health, or where you live, eat, work, and worship. The new law also allows community health workers and doulas to be reimbursed by Medicaid for their work to address these important needs through the state's Case Management for Children and Pregnant Women program. More than half of all births in Texas are covered by Medicaid. HB 1575 addresses a critical gap in maternal health care across the state by strengthening the way Medicaid helps identify and impact underlying non-medical issues like housing, nutrition, transportation, employment, and more. The legislation was sponsored by Representative Lacey Hull and Senator Lois Kolkhorst. High-risk pregnancies are about twice as likely to have had a non-medical health need recorded on a healthcare claim as non-high-risk pregnancies, meaning it's imperative that we screen all women and especially high-risk pregnancies for these non-medical determinants, because if we can catch them upstream before the doula and the obstetrician is seeing them at the birth, then we have a lot more chance of a healthy pregnancy there. Okay, so let's go ahead and start our discussion. I'm sorry, I'm getting a call from my director. I'll answer her in a second. They're having trouble getting in, it sounds like. Representative Rose, you were a primary sponsor for the extension of Medicaid to 12 months versus 60 days. Why was supporting this measure important for you?
Good morning, Dr. Sampson, and thank you. Thank you all for extending the invitation to be with you all today. I apologize for my communications. I'm talking to you all from my phone, so it may look a little crazy today, but I'm here. But one of the things that compelled me to file this legislation was I heard a report, or I saw a report on Twitter from an organization called the Affairs Center, and the report talked about how Black women were dying at alarming rates due to childbirth, and it really piqued my curiosity. And I mean, it just, well, not necessarily my curiosity, but it just kind of left me dumbfounded that women were dying due to giving birth to children. And then I became a part of a committee. And of course, even when I read it, I, didn't have the answers or the solutions. And then I became, I'm a member of the Human Services Committee. And that particular, back in the we're in the 88th, 87th, 86th legislative session, I was on a special group, or 85th. I was in a special group, special work group that dealt with different things that related to maternal health. And what I found was the number one recommendation from the maternal mortality and morbidity committee was the number one solution was extended Medicaid services. Mm-hmm. And it just seemed to me like a no-brainer. And so I filed the bill. And of course, the first time I filed it, the bill didn't go anywhere. And the second legislative session, when I filed it, Speaker Phelan contacted me and asked me if I could make it, if I would allow my bill to be a part of his Healthy Texas package. And who tells the speaker no? Because, when you have that level of support, you have a greater chance of your bill getting done. And of course, my answer was a resounding yes. And so we worked last legislative session to get it done. And so, we had some hiccups and we came back this legislative session. But the fact that women were dying at alarming rates to illnesses or to complications that were preventable, cardiovascular, hypertension, postpartum, all of those things are preventable. And they stated that 90% of the deaths were preventable. I mean, that was just unreal. So that's how I really got involved with working on this, doing this work in maternal health.
Mm-hmm. Well, I'm so glad that you have used your platform to try to advance access, because what we're really talking about is increased access to what can really be basic care sometimes, like just getting in early enough, right? So we really appreciate it.
Exactly.
Dr. Ortique, I'd be curious to hear from you. I know that you are on that committee that issued that report. And I'm curious how you think that the HB12, which extends it for 12 months, plus an added measure to screen for social determinants of health / non-medical determinants of health, how do you think that those two combined could help reduce what we're seeing here with these trends in mortality and morbidity? Oh, you're on mute.
I hope we don't get fined every time that happens. But that's such a great question. And I have to take the opportunity to thank Representative Rose for not only introducing the bill in the previous session, but persisting when initially it was 6 months that was approved, which wasn't something that was actually able to be instituted in our state. So we really, really appreciate the support and appreciate your commitment to improving health and particularly maternal health in our state. I really do think that the two pieces together are first steps. Our first recommendation is really that there would be healthcare across the reproductive life course. And so I'm like cheering the 12 months as being that first step in that direction. It allows a woman to have some continuity of care. And so I think it also the 1575 adding in the non-medical drivers. And I like that word driver because determinant feels like if you were born in a certain area, or if you don't have access to healthy food or transportation, that your life course is set, rather than acknowledging that if we institute some changes, that we can actually change the life course. And so where I'm going with that is just acknowledging that addressing a woman as a whole, as opposed to just having a piece of time with her across pregnancy, is critical in improving the life course. And so things that are identified during the pregnancy can be addressed across a longer period of time. There's lots of research that shows that if you have at least 12 months to address some of the problems that are identified during pregnancy, you can improve a birthing person's health such that her next pregnancy might even be healthier. So it's a life course kind of approach to the issue.
Yeah, life course. Thank you. Yeah, I think that's a great point. And it was something I didn't realize, even though I had, let me pause for a minute. Serena and the tech people on here, I'm sorry, my Healthy Start staff couldn't get the link. So now they're logging in with my link, and that's why they are in the, y'all are up on the panel. So you can just take your video off for now, and then they'll probably move you into the bigger room. Sorry for that. Yay, technology. Okay. But those are the real heroes, those Healthy Start people. Thank you so much. But yeah, I hadn't realized that before I got into this work. I hadn't really thought about it, like how fragmented women's reproductive health is. And that you'll see one provider, like for me, I used to go to see gynecologists that wasn't even an OB. So then when I got pregnant, I had to see the OB. And then after that, it's the, I was going mostly to the pediatrician, and then a different person for postpartum, and then a different person for behavioral health, obviously, in different clinics. And then those people aren't talking. So I think what you're saying about trying to zoom out and a life course model is very timely, for sure, and part of the solution. Let's hear from our resident doula on here. Yenny, I'm curious for you, how do you see doulas as important to pregnancy and postpartum for women who are on Medicaid, let's say? So typically with the people who are getting on Medicaid, from what we've seen in our program, sometimes they can't get on as soon as they know they're pregnant. It takes a little while to get on. And so they may be different from a client that's calling you the moment that they know they're pregnant. They've been looking for a doula. They're ready to get connected right away. Can you talk to us about how working with the, having access to a doula may be beneficial to women who are on Medicaid?
Yes, so thank you so much again for offering this space and really co-creating this space to have the conversation. So I always say that one of the most important things that doulas provide, besides the emotional and physical support, is education. When we provide education to families, we are providing them the knowledge and the tools to make informed decisions and to understand what happens within their bodies throughout pregnancy and also postpartum. So when we think about Medicaid, and specific to 53% of expectant parents being on Medicaid in Texas, that's a huge population. So that when we go into underserved communities, we see a lot of vulnerable families that are there. So we are able, when we go into underserved communities, provide that educational support, emotional and physical support to perhaps families who are facing food insecurities, housing insecurities. As a community-based doula myself, I have supported families who are homeless, refugees and immigrants, a huge advocate for pregnant inmates, and even teen pregnancy specific to foster care, children in foster care, victims of human trafficking. There's a large population, a huge community that really needs the support, but they don't have access to doula support because they cannot afford those services. So with the proposal of HB 1575, we will be able to continue our support in the communities because we've been doing the work for so long, but we really rely on that philanthropic support because this isn't something we can do full time, unfortunately, because it's not financially stable for us to do that, even though we have the heart and the willingness and passion to really support the families in underserved communities.
Mm-hmm. Yeah, and that's a great point about what you're talking about is being able to provide more education to higher risk groups, right? And what I've seen just from learning about this through numbers and talking to people is that once somebody is on that high risk track, they need special attention. And if they don't get special attention to the high risk, like maybe if the housing needs aren't addressed, then the chronic stress elevates, then the hypertension gets worse. And so she's going into the childbirth with compounded high risk. Whereas if we had been able to intervene earlier and get her empowered with some resources and tools, maybe that could have been prevented. So I really appreciate that.
Right. And I always say too, excuse me, is that our womb doesn't have only the ability to create life, but to change it. So when we think about the study of epigenetics or transgenerational trauma, if we are not centering the parent, this doesn't only affect our generation, but our future generation as well.
Mm-hmm. Yeah, that's great. We talk about that a lot in our program, and we've heard feedback from participants in Healthy Start that say, I'm learning to do things differently than when my mom was pregnant. And then I'm going to teach my daughter how to do things differently. And so we're seeing this intergenerational change, which is really powerful. Representative Rose, what are some ideas you might have for how can all providers help raise awareness about these benefits, given that the benefits are not immediately available? Like, we want people to know it's coming, but we also can't just turn on the light switch.
I think one of the things, the most important thing providers can do is communicate with their patients, to let their patients know about the new law, and just keep them informed. Also, and I think it's not just the providers, that we need everyone to be aware of this. And I would say, since being back in Dallas, I've had a lot of providers to reach out to me, or whenever I go to a community fair, they all are aware and excited about it. And that's what they're telling me, that they're having those conversations with their patients, and that everyone, all of the staff or the nurses, everyone is so excited about it because, when you're on the front lines, you see the impact of maternal mortality and maternal health. And so a lot of them are making sure that their patients are aware. And I think that's the number one thing providers can do.
Yeah, as you said that, an idea that came to my mind was, how could we promote what politicians do, like these town hall meetings, but the providers are also engaging with their patients, or patients to be. I think that might help bridge a gap too, about like, we're here trying to share information outside of our offices.
No, I would add, if it's okay, I would add that I'm really fortunate within our facility. Like when the public health authorization was coming to an end, they did a really phenomenal job of producing materials, sending texts, emails, etc., to alert women who were on Medicaid that they were going to need to reapply so that people did not lose coverage during pregnancy. Even though we did see some of that happen, it's important to do these, I would say, community education and public health campaigns to make sure that everyone is aware of changes that are coming. And so I'm hopeful that the same sort of campaigns will be done to help our members know that they won't lose coverage at 60 days, because that's been so ingrained in women on Medicaid. And I heard it certainly from some of my patients when I've said, oh, this is coming. They're like, really? Are you sure? I'm like, yeah, it passed. So I think using every means that's available, not assuming that everyone receives their information in one way or another, but using all media, social media platforms are probably going to be really big in spreading the word.
Mm. Yeah, and I could see how programs, FQHCs and home visiting programs like us could be helping by putting that on our social media platforms too, right? And Representative Rose was alluding to that. Like, we all need to be helping raise awareness, public health. Okay, great. Dr. Ortique, in your capacity as a practicing OB-GYN, how do you foresee accommodating changes to practice that will allow for 12 months? Like, I was wondering, this is kind of a personal thought I had. Do you typically see them for well women and then that's it? And will you be encouraging them to then go to primary care? Like, how will that work?
So that's such a good question. And you alluded to it when you were sharing your experience across kind of your life course. Every person is different, and I would say every provider is different. I see my patients for their well woman care, and for me, that's not just their pelvis; it's their entire being. So I'm a primary care physician for women, and I actually was board certified in family medicine as well as OB-GYN, and so I do that. Not all OB-GYNs do, and so I think it's really important to educate women to understand who they're seeing. If you're seeing someone who is providing obstetric care only, then you are going to need to be referred to what we call a PCP, a primary care provider, who's either perhaps a family medicine physician or internal medicine physician. If you're seeing an obstetrician who is doing, let's say, they're OB-GYN and they're doing primary care for women, then many times you don't see anyone else. In fact, most young reproductive age women are only seeing their obstetrician-gynecologist across that time frame until they complete childbearing and or develop other conditions that their OB-GYN may not feel comfortable providing care. And so I thought about it when you gave us a little hint about some of these questions. And I think that considering seeing women back at 6 months, if I know that they are going to have coverage and we've identified some higher risk conditions like either hypertension or diabetes, that I'll be happy that I can see them at 3 months, 6 months, 9 months, because that's what most, if you're privately insured and you have diabetes and hypertension, you're likely seeing a PCP every 3 to 6 months until you are completely stable. And even when disease processes, if you will, are completely stable, being seen like once every 6 months as opposed to once a year is typically what would be recommended. And so I would encourage that. I think I'm wondering if the question you're asking, though, is how are we going to accommodate seeing people, just because you have insurance that lasts for 12 months, if they're not providers who accept your insurance, which is really the big piece that we see, we don't have specialists that take Medicaid often. And are there enough providers, or enough primary care providers outside of like the FQHC system? Because we know that they see only 20% of Medicaid patients. The other 80% are seen by private doctors like myself and others. And so it's a really, really, I think that's a complex question, and we don't have, I have the answer for my own practice, but I don't have the answer for the majority of patients.
Yeah, that I didn't know that ratio. So if 80% of Medicaid population is being seen by private practitioners, then there are not enough private practitioners accepting Medicaid to meet the number of people who are on Medicaid.
Yep, it's a supply chain issue, if you will. It really is an issue. And when I said that, I'm talking about for deliveries. What we know for obstetric care is that 80% of the Medicaid deliveries are done by private practitioners. Only 20% are in our state managed through the FQHC system. So I'd be interested to see numbers for non-obstetric care, but as we're talking about maternal health, that's really the place that I've focused.
Thank you. I appreciate that. Yeah, it's this is a layered issue, and especially when we talk about access and maternal health, it's beyond simply there's one piece that extends the care, and then there's a whole nother piece about supply, because Medicaid is reimbursed at a lower rate, right? So I think that might be another webinar that I have been thinking of actually, and I would love to hear, do some brainstorming and hear about ideas, because we are in this push-pull. If we expand, then do we have enough supply to meet that demand? Yenny, going back to thoughts from a doula, how do you see these anticipated benefits of this coverage for women? You talked about education. We work with doulas at Healthy Start, and one thing we have noticed is doulas in general, like you were saying, really come from this place of passion. And they seem to do a lot of caretaking, a lot of emotional labor. When I try to think about how that might look in a structured system such as Medicaid, I'm wondering, what do you see? How do you see that translating? Do you see doula care changing at all as it gets delivered through Medicaid?
That has been one of my main concerns, is we are not a regulated profession. And as I look throughout our country and states that have implemented Medicaid reimbursement, there has been a lot of policies implemented that may restrict us from everything that we offer. So that has been definitely something that I have been concerned about. My hope is that as people are continuing to expand this and create policies, that they really think about autonomy, that they think about the way that we nurture and nourish families in such an intimate space, because that's what it's about. Like, it's about the holistic approach. That's what's making a difference, is that the care that we provide goes beyond the physical. It is emotional, like you said, a lot of the things that we do. Now, our hope is that families, there are different types of doulas, birth doulas, postpartum, full spectrum. So our hope is that families are supported throughout their perinatal period, from pregnancy to postpartum, that 1 year postpartum. And one thing I was thinking about when Dr. Ortique was talking is, for me, having been working in underserved communities, I think about those who have been on Medicaid and maybe when they try to switch providers or get an appointment, there are 2 to 3 month waiting lists. And this is just for prenatal care. So that has been another concern of mine, is that as we extend and hopefully expand, we really need to open up opportunities to have more providers be within the network, but also we have to do a better job at integrating midwives as well. And I don't think only CMMs, this is where we see a lot of the shortages, because there are different types of midwives. So I think that we also have to be creative in integrating CPMs, traditional midwives, into the care and seeing how that can work on a systemic level.
And I noticed the term community-based doula recently. Is that a different type of doula?
Yeah, so I can say myself as a community-based worker or a community-based doula, a lot of the things we do is like a community health worker, which is why I'm certified as both. The difference is that, community-based doulas, we do home visitations. We really focus on making sure that the family is connected to the correct resources that they need. So for instance, if I do a home visitation, I'm looking to see, do they have food in the fridge? Do they have running water? Do they have a home? And making sure that we are connecting them to those resources where they can get assistance with that. And also looking for things that may be hazardous to the parent and to the newborn. That's very important, but not all doulas do that. Not all doulas are community-based or community health workers.
Yeah. Okay. That's helpful. Thank you. Representative Rose, I have a question for you. What are the potential challenges or barriers that you foresee from your platform, your positionality, to the implementation of these policies of HB12 and 1575?
For both, well, I would say for HB12, the only barrier I see is that if, the federal government has, that could be the only barrier, but keep in mind, this time when we filed the bill, we did it a different way. We filed a state amendment plan instead of having to go through CMS. And so hopefully, I'm trying to have a positive outlook about this, and hopefully there are not any barriers, but I see that to be the only one, because the state is behind this 100%. And I believe the state wants to do everything it can to make sure that it's implemented. And so I think that's the only barrier, and it's a barrier that I really don't see, but I think that's the only one that there could be.
Right,
Yeah.
because as Dr. Ortique said before, the last session, they did put forward 6-month extension, but I know that had to go through CMS, and then it still was never approved. I'm curious, what do you think? What were the elements that helped turn the tide this time? How did we get from 6-month maybe to 12-month? The state is fully behind this.
Oh, we're post-Dodd. We're post-Dodd decision. And that's one of the things, and I even told the governor, this is a pro-life bill. If we're going to be pro-life in Texas, let's be pro-life for everyone. And I do believe that that made a huge impact on it, because even groups such as Right to Life, Texas Public Policy Foundation, they all were in support of it this time, because they understood if we're going to require women to give birth, then we need to make sure they have the resources needed to carry out those births and to have a healthy and be healthy after their pregnancy. And so I believe that, and I know it did, because even some of my colleagues stated that to me, that was a huge factor in why they were supporting the bill, those who had not supported it in the past.
Yes, that's beautiful policy advocacy, is really framing it to say, okay, let's put our money where our mouth is. If we say we care about families and babies, we have to support healthy pregnancies.
Exactly.
Right? Okay.
And I really believe now the House, I would say, was pretty much for it, but I really do believe that had a huge impact on the Senate.
Yeah. And now I've heard with HB 1575, the one for non-medical drivers and the doulas and CHWs, that's a bit more fuzzy about when it will be effective. Do you know anything about potential dates on effectiveness for that or potential barriers there?
The only barrier there could be to that one if the agency doesn't implement it. But we're trying to do a better job. One thing that happens, we pass legislation, and sometimes the agencies can be resistant. But we put I believe there was legislation passed, and we're all as members trying to make a better effort of making sure. It's like you pass the bill and you just assume that the agency is going to implement it.
Right.
But then the next time you turn around, you find out that they didn't. And so we're just trying to do a better job of keeping a track of what's going on to make sure that the bills are implemented as requested by the legislature.
Yes, I love that. We were just learning about that yesterday at the Baker Institute about how many laws have passed, but then they may never be implemented because there's this missing piece of accountability, making sure that the organization is implementing it.
That's correct.
I was going to jump in on that one. It's interesting. I really appreciate this opportunity to actually look at House Bill 1575 because I've said things about it like, oh yeah, and doulas are going to be covered and non-medical drivers of health. And then when I really read it, before this panel, there's some things in there that are interesting. Like it says that providers will have to get consent and document that they had consent to do the screening questions on the non-medical drivers of health. And for transparency, those questions are supposed to have been asked. Seeing a person, a human being comes to your office the first time, you should want to know whether or not they have housing insecurity, if they have difficulty with transportation, because that impacts whether or not they can come to their visits. If they have the resources to pay for their medications, are they going to have to make a choice between the things that you prescribe in your office and feeding their kids? If they can get to your office or not in around childcare, things like that. Because like in the pandemic, when we shut our office down and said no children allowed, then we started seeing a drop off in women attending their prenatal visits. And so just acknowledging the intricacies that life, like you said, where you were born, where you were educated, where you live, where you play, where you work, how it impacts your health. Those are questions that we're supposed to ask anyway. It's sad that we have to have legislation to, kind of codify asking those questions. But I wondered, now am I going to have to ask my patient to sign something? I didn't know what that consent meant. And so I'm interested to get further detail on that. And then with regards to the doulas, it's really about care coordination. It's not actually what Yenny has so I have really enjoyed learning and hearing your description of what a community-based, holistic approach to doula care is, because unfortunately, that's not exactly what's in the bill. And so I think this is an opportunity for us to look at this and say, okay, this was a great first step. And what are some things that might be done to refine it more going forward?
Mm-hmm. Yeah, that's when I read it, I thought, oh, this is really about case management. This is about extending case management through doulas and CHWs, which isn't a bad idea, but that's definitely case coordination, and it is a different type of doula work. The doulas, we've been training birth doulas, and that's not within their scope typically, is to connect to resources. So it's interesting to me to watch the legislation in general, really trying to, all over the country, trying to move towards how can we help build up a woman's health starting early in pregnancy and in her environment. It's not just about what's going on inside her body. So I am glad that overall we are moving towards more systems connecting, more of this holistic approach. And I'm very happy that Texas has extended to at least 12 months, because we know that most of the deaths in maternal mortality happen after they leave the hospital. A lot is happening in the community with the domestic violence, substance use, suicide, homicide. I was just reading yesterday about how even hypertension you can't just stop watching it after the birth. Like, you've really got to pay attention in the postpartum period too. So postpartum coverage is essential for health. I think this might be a good time to open it up for questions. I have not noticed any questions in the chat. So, Serena, can you help me with that? Like, do we just open it up and ask people to raise hands, or do people need to put questions in the chat?
Yeah, people can feel free to enter any questions they have in the Q&A portion.
Oh, Q&A. Oh, I see now. Okay. All right. We'll give it just a minute to see if anybody has questions. Yes, go ahead.
I just had to add, one of the most frustrating things about House Bill 1575 is to see this come to light without the voices of doulas and community health workers. That has been the most frustrating thing, because again, one, we are not a regulated profession, but to me, it shows that the outlook on birth is still kind of the same. You know, when we talk about physiological versus pathological, kind of tying that to doulas as well, when we do a lot of that holistic approach and go home with clients and really nurture them and nourish them throughout their healing process. So if anyone is on this call that is part of this policy, making these policies, I really suggest that you really include our voices, our experiences, because a bill that's being created without really understanding what we do, that is surface level change. And what we want to see is something that goes beyond the surface, something that really helps improve birth outcomes. You know, we think about adverse effects and all of these things, but something that goes beyond that surface, because that's when we get to the root of the problem and see effective change for a long time.
Yeah. I just wanted to thank her for that feedback. And, you know, most members, when they present a bill, I guess we're just under the assumption that they've done their due diligence. When my colleague brought the bill forth, I did notice, now that you've mentioned that, and I didn't look at it from that way, so I'm really glad that you made that statement. So it's something that we make sure we look into. I thought she had been working with the doula community, but now I recall in our committee hearing, I don't think there was anyone from the doula community that testified for the bill. And now I've slept since then. I may be mistaken, but that is something important. And I guess that is a question that, I guess from my perspective, being on the committee, probably was a question that probably could have been asked. But thank you for bringing that to my attention. And actually, when I see her tomorrow, I'm gonna ask her about that and try to address some of the concerns that I've heard here today, to see if she will follow up on those.
Thank you so much.
Absolutely.
Right. I do see a couple questions in the chat. Someone is wondering if we have any resources / flyers that we can share on social media. I was just thinking, I know we could try to make one just to describe the bills, I think is what they're talking about. Do any of you have them, or know of maybe an organization has created some easy to understand infographics or visuals?
I just had the graphics that I did, once, after the session or whenever you pass legislation, you post a graphic on social media. I have those, but I mean they personalized to my office. But I think that'll be great. I think, and it is something that we need to continue to promote, to just let women know. This has really been helpful. I guess I've had so much going on this interim. I hadn't even really thought about that, but I guess we do need to continuously put it out there so that people would know. I just did recently send out a newsletter to all of my constituents, and I included it in there. But yeah, that's a great idea to just continue talking about it, even though, yeah, I think that's a great idea.
Yeah, I think so too, because what I'm noticing is because extension happened, but expansion didn't, there's this big middle part of crisis that's happening now because so many people are off and having to re-enroll, and that's getting a lot of press and a lot of stirring up a lot of anxiety and worry that we're not going to have it. So I think you can never just provide too much education between policy and the actual implementation. It's confusing for us general people.
Yeah. Yeah. Excellent.
All right. We've got a midwife we know and love on here, Catrice. She's saying we have 6 midwives present, and we're curious to know how this HB 1575 is inclusive of midwifery care. Are we considered community health workers, or are we under another category? Does anyone know? Because I don't know. I can go back and read the bill. I don't know if midwives are mentioned in HB 1575.
No, it's specific to community health workers and doulas. And that's why I mentioned how it's very important that when we think about systemic change, that we include midwives in what we are doing and extend beyond only certified nurse midwives, because we have a lot of CPMs here too. But I did not see that in the bill is specific to community health workers and doulas. And even as a community health worker, you either have to take a training through the state, or if you have worked in the community for over 1,000 hours, you can apply to become a community health worker.
Okay. Rhonda says, why are licensed social workers routinely left out of these conversations/presentations? I'm a social worker. Social work is a multifaceted discipline, can not only provide targeted case management, but also provide clinical services to include mental health counseling and psychotherapy. How do we rectify this in the future? So Rhonda, if you can type in here, or you could raise a hand. Are you talking about left out of when people are trying to influence policy, like during the policy conversations? Why were they left out of that? Or why are they not being included right here in this policy conversation? So I can better answer your question.
While she's doing that, I'm going to jump in, McLean, if it's okay, and just say this is one of the things that I'm super fortunate. If I want a social service consult, I just say to my medical assistant, hey, call social services, and someone pops here because I'm physically located at a place where there are. And at FQHCs, they have that same luxury, but most private physicians do not have that luxury. And there's, the issue again of coverage. And so we've thought and talked a little bit about looking at where are the high volume Medicaid providers, and shouldn't there be a social service worker in the vicinity of your high volume obstetricians, because they need, I don't know who Rhonda is, but absolutely, social workers have to be, they're an integral part of providing comprehensive care to anyone who, if you're on Medicaid, I think we should use that as a proxy for you. You likely are going to have some needs that may not be able to be met by your own resources. And so we have to be able to provide those wraparound services. I think social service is absolutely critical.
Yeah. I'd love to see behavioral health in every obstetrician and pediatrician office. I think it's a great place for LCSWs, LMSWs to really help not put the burden on the OB provider to provide the mental health screenings and interventions. Like she's saying, in social work and LPC degrees, all of those, we are trained in behavioral health. So it would be great to be officed in the same places.
Dr. Sampson, I wanted to jump in on that too, because one thing I noticed and a lot of people aren't aware of is that when it comes to community health workers and doulas, a lot of the job opportunities, specifically for community health workers, because doulas it's a growing profession in our community, but a lot of the things that we do is based off of philanthropic efforts and funding. So it's not like maybe we are a medical assistant where there always will be jobs for us or nurses, but this is a way that it can be a sustainable profession where we can integrate them into hospital systems, community-based organizations. So when we see bills like these, it's kind of a first step in integrating doulas and community health workers and also building more job opportunities or creating more job opportunities.
Mm-hmm. It's helping to expand the perinatal workforce, which goes back to the blueprint by the Biden-Harris office, right? Is the federal government is encouraging us to really try to move towards a more holistic, and CHWs, midwives, doulas, LCSWs, behavioral health workers, these are all helping to expand perinatal workforce. Okay, Emily Jackson asks, I'm currently working for a FQHC as a healthcare advocate. I'm interested to know what are good resources that are available to educate myself and others on the bills to be able to support patients coming to our clients. I know that when I'm trying to find information that I can digest and give towards community-facing members, I've been going to, I hope I remember it right, Cover Texas Now, I think is the name of it. Legacy Healthcare Clinic usually has a page on their website that describes recent bill passages. Like Dr. Ortique was saying, Texas Children sometimes has a page. Like some websites at some organizations actually have a page on recent bills passed, and it's in more plain language than having to read just a bill when you go to Legiscan or something.
And usually that information is provided by the government relations person.
That's
because that's usually how that information is translated over into the different facilities. So I'm just curious as to why that information may not have, trickle down. It kind of why we're having this conversation and talking about how, information can be, we can bring more awareness, but normally, and do you all know which facility is she?
It says an FQHC, so.
Oh, okay.
They should probably have a government relations, and if they don't, then a bigger FQHC certainly would. If you're at a small one, the big ones like Hope and Legacy, I know they have government relations positions.
I think that's really illustrative of one of the issues. If you're paying attention to this topic, if this is your work, then you feel like you get the information all the time. I was on the volunteer. Texas Medical Association has quick blurbs on each of the bills that relate to health, and they divide them out according to maternal health, et cetera. And so we're getting that information, but in my own office, my other partners if I forget to send them an email, they don't know. And so I think that's where I'm going. I think that whoever brought up this point is hitting the nail on the head. Certain people feel like they're getting the information over and over again, but we're kind of siloed and it's not getting out in the community. And I think that I would be asking for suggestions of how to improve that from people in the community. How do you want to receive the information? What's the best way for us to, push information out?
Yeah, that's a great question.
Mm-hmm.
So put any ideas you have here in the Q&A or chat. Antonia asks, does this extension, the Medicaid extension, apply to undocumented women?
If they're eligible, it applies to anyone who is eligible for Medicaid. I mean, anyone that's, I get what she's saying. If a woman is pregnant and she comes in.
Yeah.
Yeah.
Do you know if this is for also CHIP perinatal? Because usually those who are undocumented, instead of getting the full coverage of Medicaid, it's CHIP perinatal. So I'm unsure if that extends it 12 months for them as well.
I would have to admit, this is a good question. This question did not come up at all when we were going through this process. So this is really a good question. And I don't think it should, I don't think it would exempt them, but if they go to the hospital now, currently, if they're able to go to the hospital and deliver a baby and receive it, I don't see why it would be, but it's a great question that I don't have the answer to, but I would definitely find out because I would like to know that myself.
I think this is where our HHSC rep would be able to answer the question, because I unfortunately have heard the answer and I do not believe that it is yes, but I would, defer to an HHSC rep to clarify that.
Yeah.
Mm-hmm.
Yeah, because I don't.
No, because there is a difference between Medicaid and CHIP, and undocumented clients or patients usually don't get Medicaid; they get CHIP perinatal.
Right.
Even when they're okay. Let me ask this question. So,
CHIP covers the baby.
Pardon me. Yeah.
CHIP covers the baby, because we can say that the baby delivering here is then going to be a citizen. But so that's like CHIP perinatal doesn't cover contraceptive services, and it's not traditional Medicaid, right?
Right.
So is that the services that they're currently receiving? If they are undocumented, they can only receive the services for. I'm telling you, all have opened up something that I wasn't aware of. But it just seems that if an undocumented person goes to the hospital or becomes pregnant, if they were eligible to receive it, then they will continue to be eligible to receive it.
When they apply to receive benefits from the state, they usually don't get Medicaid. It's typically CHIP that they get. So those two are different support, even though it's from the government or for the state, but those are two separate insurances.
And I understand that. I know exactly what CHIP is, but my point is that if they go now, and I mean, they're not, I mean, do they just deliver the baby and doesn't receive they don't receive the 2 months now?
They receive the 2 months under CHIP, but that's it. So after 60 days or after the 2 months, that's all that they receive.
Well, I think that will be eligible.
Well,
I can verify that, but I think whatever they receive, I mean, because I don't, the bill doesn't make a distinction. It's for whoever was eligible. The same people who were eligible for it at 2 months will be the same. I mean, the 60 days, 2 months will be same people who are eligible for the extension.
Yeah, and it's interesting in that HB12, Yenny, it says that CHIP has already been expanded to 12 months. So I'm wondering if that just means just for the baby, or is it like you're saying, is there going to be this matching where it's like now with each one of them, would have 12 months? We can try and get some clarity on it.
Yeah, my staff is on the phone. My staff is on the call, so we'll make sure we look into that and find out.
Yeah, I mean, I should have gotten a PhD in Medicaid because it's so complicated always.
Yeah.
Dr. Roberson says this is an opportunity for Texas to be in a bit of a leadership role in terms of articulating the doula policy message in a deeply conservative South. What are your thoughts on that, Yenny?
I think that the reality is that based on the actions that we have seen from those proposing the bills, we are not included in this. And I can say even years ago, when I reached out to certain leadership in the state to talk about doula services, they didn't really want to hear what I had to say. So for me to see that a bill was implemented without understanding what doulas do, without our voices, without our experiences, yes, we can be leaders in this, but I feel like it's already been shown that we aren't at the center of this bill that is supposed to help the community and help us. So while I am hopeful, because that's what I want to really have faith and have hope in our system, I'm just really hopeful that they look at examples from states that have been very successful. So going to Rhode Island, looking at their policies, Florida, California has done really well also. Those have been really prime examples of communities that have been thriving for doulas and also community health workers. But from what I have seen so far, I can speak for our community. We don't feel seen or heard. We feel like this is being implemented without our experiences and our voices.
Okay. Yeah, it would be nice if it was required to have to hear from either the community that's being affected and or the providers that are being affected, right? When there are big policy changes like this.
Right, because even when we talk about case management, like I was mentioning earlier, there are different types of doulas. So community-based doulas, yes, we've done case management because we do a lot of the role of community health workers, but not everyone works in that capacity. So how are we really going to support families the way that we have been doing without these policies?
Right.
And I think too, even with the case management, I don't know if attending a birth is actually going to be covered. I think it's just the support throughout pregnancy and postpartum, but it's really important for us to be at the birth as well. We shouldn't have excluded that from the support that we provide for families, because again, this is something we've been doing for years with philanthropic efforts and with funding. But if we're going to do this, then we really have to look at our practice and what we do and how we have really benefited from being a community, from helping families holistically.
Can I make a suggestion? Who was the HHSC person? Was it Valerie? I suggest that, a conversation be had with Valerie because, the more I think about it, Lacey Hull, whose bill this is very thorough. And I know because you're saying, Yenny is saying that, that it's been implemented and all with our doulas. I don't know if she did. She may have spoken with the doula group, but I don't know. Is there I'm not a government relations, but do the doulas have a statewide organization that all the doulas belong to?
So it just started last year because of this. It's called the Texas Doula Association, and that was created because when we had our first meeting last November about the bill and implementing this, a lot of people weren't at the table who are leaders in their profession and being a doula. So right now there is a Texas Doula Association that is working closely and following these bills, and also the changes that are coming about for our work.
Okay, good. Michelle is on the call and she says, I work for Little Angel Network, a nonprofit that supports women and families who are grieving the loss of a child during pregnancy or birth. I think this information would be great to share with our audience in an easy to understand format / graphic. I do too. I'm going to do some digging around and see if I can either find something that exists or ask one of our wonderful graduate students to try to come up with something. And because it's not just the extension, it's also like y'all were just talking about, like who's going to be rolled over, if anybody, who's going to need to, if you start now, does that mean you'll be in the 12-month cohort, or does that not start till March? So I think we need to get some easy to understand details there.
I think the CHIP perinate is, it's a very, it's tricky because CHIP perinate isn't Medicaid, and Medicaid is a federal program. And I think the answer, if you were on CHIP perinate and you were undocumented, you're not going to get Medicaid. If you're on CHIP perinate as a U.S. citizen who does not qualify for pregnancy Medicaid, then you can roll on to Healthy Texas Women and some of the other programs, Healthy Texas Women Plus, some of the other programs that are available to help provide resources. But the question for an undocumented person delivering here is unlikely to, if you don't qualify for Medicaid, you're not going to qualify for a Medicaid extended program.
And that's correct. That's why my statement was whoever was eligible prior would be the same people that are eligible for this. So if undocumented people were not eligible prior to this bill, then I don't think they will be eligible after the bill is, now that the bill is passed and being implemented.
Mm-hmm. Okay. And thank you.
So that's another, I really think that's another area of potential advocacy. CHIP perinate has always been, it's unconscionable that you can deliver someone, but you can't provide certain services because the unborn child or the child was covered and not the woman who's carrying the child. That is, I think that's an area that needs to be looked at.
Mm-hmm.
Sounds inhumane to me.
Mm-hmm.
Yeah. And I specifically have worked with immigrants and refugees, and you have to think about too, they're at a higher risk of developing postpartum depression, anxiety, and psychosis. So when we're cutting off these really important resources at 60 days, but we are, trying to help them throughout their perinatal period, it's really kind of an injustice to me, because trauma, especially something they may be running from, can really affect them and their baby and what they experience. So we definitely need more advocacy for immigrants and refugees and those on CHIP perinate.
Yeah, and thank you to the audience who's been chiming in. They say that Antonia was saying, I have teen undocumented students being refused medical care because Medicaid is ended immediately at birth. And another person saying CHIP perinate women have to apply for emergency Medicaid to cover delivery. Yeah, okay. And thank you, Christy. She gave us a reference sheet from Texas Collaborative on Healthy Mothers and Babies. Okay, this is all okay. Yeah, there is some good information in the Q&A about CHIP perinatal and Medicaid for pregnant women. Yeah, it says Medicaid for pregnant women, you must be a U.S. citizen. So if you're not a citizen at the time of birth, that's what's happening, right? Is that you don't have the coverage, but then the baby can get on CHIP.
And that's something else that I used to see, especially working in within community clinics. So someone who was on CHIP perinatal, they only were able to receive 2 postpartum visits up to 8 weeks, 6 to 8 weeks. So when we go into the community clinics and we have those long waiting lists, you know, you go past the 6 to 8 weeks and now they have no coverage at all. So that's something else that we see in our community.
Yeah, I mean, it's really when you look at all of these factors and all of these various systems and what did we used to call it? Now I'm thinking like programs, like a needs-based programs, right? Needs and means-based. That there are so many different factors that create barriers to consistent quality care. It's really not as surprising that we're in a maternal health crisis, you know, and that's why when I'm having these conversations about the horrible rates of maternal mortality and the horrible disparities, and a lot of people want to know why, and they think that there's going to be one reason, and it's a confluence of a lot of things that create barriers within the systems, moving through different systems and trying to qualify for different benefits, the insurance differences, the structural problems. There are just so many.
Yeah. We like to say there's a complex interplay of everything, and yet I appreciate this conversation, but I also have to still applaud the work that Rep. Rose did, because House Bill 12 is a first step. It's definitely, and it's a huge step in terms of improving access and continuity of care for women, particularly high-risk women. And so, you know, I never want to lose the positive as we actually, you know, dive into some of the other factors that play a role.
Yes. I mean, at a minimum, research is showing that the states that have expanded Medicaid or extended, because the federal government was talking about extending, you know, at least a year ago, they were encouraging states to extend. There are better maternal health outcomes. Like at the very least, it does help bump up some maternal health outcomes, just as, like you're saying, the continuity of care. And then as we strive towards expanding the perinatal workforce, we also strive towards including more voices of the community. So the women and families who are being affected, and also hearing the voices of the workforce, midwives, doulas, social workers, even medical assistants play a role. I mean, when I think about how many nurses are in those situations too, right? So I think we're moving in the right direction. It may be slow, but at least we're moving in the right direction. Are there any other questions that we have from our Q&A? Let me check to make sure I got everything. Okay, I'm having trouble seeing it. Okay, Dr. Jerry Roberson is asking, is there, or what is the role in there for fathers in this conversation? And the conversation is really about extending care during the perinatal phase so that our systems are more connected, so that the conversations are more connected, that high-risk things are being caught early, intervened upon early. We have different perspectives from different types of providers who can lend expertise. So how do we see the role of fathers in this conversation?
I think fathers play a huge role. And I think, number one, when they are present, that they are able to have eyes on the situation without actually experiencing it in the same way that the birthing person is. And so they can be that critical connection. They can be the person who advocates. They can be involved in community engagement and education. I think the more people that recognize, when we talk about signs of high risk situations and are able to voice, because, a father sees what's happening both with the baby as well as with the mom. And so I think they should be encouraged to be involved and to help in the advocacy process.
Mhm.
And I can say, as doulas, we don't only support that gestational parent. Anytime that we support an expectant parent, we support the entire family. So for us, it's important that when we educate one, we educate all. And also, as we implement certain programs within our community, like community-based doula programs, we ensure that when we open up focus groups or design sessions, that we are inviting everyone, whether it's someone who has a partner or their support person can be their parent or a grandparent. Everyone who is part of their support system has a voice because they also see the experiences in their community.
I love that everyone who's a part of the experience has a voice. Mhm. Yeah, I'll never forget in focus group when we were talking about, and it wasn't with Healthy Start, it was years ago, and just talking about postpartum depression and the experience of that. And people inevitably bring up the husbands and or the partners. And I'll never forget that one woman said, "I want my husband to be my witness." And it just really resonated. She said, "He's the one that sees me at my darkest and sees me at my lightest. And he's going to know when something is off. And I want him to witness it. And I want to feel comfortable being able to show all of that to him too." And I think that the more conversations we have where we really bring that, I call it shaking up the myth of the blissful motherhood. I mean, we have to talk about the realistic issues that go on, and it is a very dangerous time. Childbirth is dangerous business. Takes one wrong move for tragedy to happen. So I think the more people know and the more conversations are happening in a normalizing fashion, the more women and dads and partners and grandparents and all the people that are helping them are able to have honest conversations. And I think that's just going to continue to help. Well, I thank you very much for your time, everyone. I think it is about time. Yeah, it's about 1:27. So we really appreciate your time. To the panelists, I very much appreciate your time, your expertise. Thank you for your passion in continuing to try to make moms matter, to make families matter. Thank you for never giving up in the policy atmosphere that I know can feel very contentious. And we just appreciate it, Rep. Rose, that you have been a tireless advocate and you're always willing to come on these kinds of things and connect with the community members.
Thank you so much, Dr. Sampson.
Honored to be here. Thank you.
Thank you.
Thank you. Thank you, everyone, for coming.